Okay, this is Chapter 17 of the ATI Mental Health Neurocognitive Disorders. If you find that my recordings are helpful, just share them with your students that you're with. Neurocognitive disorders are a group of conditions characterized by the disruption of thinking, memory, processing, and problem solving. Treatment of clients who have neurocognitive disorders requires a compassionate understanding of both the client and family. Types of cognitive disorders. Neurocognitive disorders, recognized and defined by the DSM-5, include the following: delirium, mild neurocognitive disorder, and major neurocognitive disorder, commonly known as dementia. Delirium tends to be short-term and reversible. Mild neurocognitive disorders may or may not progress to a major disorder. Major disorders are progressive and irreversible. Major and mild NCD subtypes are further classified. Alzheimer's disease is neurodegenerative, resulting in gradual impairment of cognitive function. It is the most common type of major NCD. It is important to distinguish between a cognitive disorder and other mental health disorders that can have similar manifestations. Depressions in the older adult can mimic the early stages of Alzheimer's disease. Assessment. Risk factors. Risk factors for delirium include physiological changes, including neurologic, Parkinson's disease, Huntington's, metabolic, which is hepatic or renal, fluid and electrolyte imbalance, and nutritional deficiencies, cardiovascular and respiratory disease, infections such as HIV and AIDS, surgery, and substance use or withdrawal. Other risk factors for delirium include older age, multiple comorbidities, severity of disease, polypharmacy, intensive care units, surgery, aphasia, restraint use, change in client environment. Risk factors for neurocognitive disorder and AD include advanced age, prior head trauma, cardiovascular disease, lifestyle factors, and family history of AD. There is a strong genetic link in early onset familial AD. Expected findings. Delirium and neurocognitive disorder have some similarities and some important differences. Clients who have NCD can also develop delirium. Defense mechanisms. Clients often use defense mechanisms to preserve self-esteem and to compensate when cognitive changes are progressive. Denial. Both the client and family members can refuse to believe that changes, loss of memory, are taking place, even when those changes are obvious to others. Confabulation. The client can make up stories when questioned about events or activities that they do not remember. This can seem like lying, but is actually an unconscious attempt to save self-esteem and prevent admitting the inability to remember the occasion. Preservation. The client avoids answering questions by repeating phrases or behavior. This is another unconscious attempt to maintain self-esteem when memory has failed. Diagnostic procedures. There is no specific laboratory or diagnostic testing to diagnose NCDs. Definitive diagnosis cannot be made until autopsy. Testing is done to rule out other pathologies that could be mistaken for NCDs. Chest and head x-rays, electroencephalography, electrocardiography, liver function, thyroid function, neuroimaging, blood electrolytes, vision and hearing tests, and lumbar puncture. Screening assessment tools. Confusion Assessment Method, or CAM, is used for delirium. The Nealon-Champagne Confusion Scale is for delirium. Functional Dementia Scale. This tool will give the nurse information regarding the client's ability to perform self-care, extent of the client's memory loss, mood changes, and degree of danger to self and others. Brief Interview for Mental Status, used for clients in long-term care settings. The Mini Mental Status, Functional Assessment Screening Tool, Global Deterioration Scale, and Blessed Dementia Scale. This tool provides the nurse with client behavioral information based on an interview with a secondary source, like a client's family member. Patient-centered care, the nursing care. The best way to prevent and manage delirium is to minimize risk factors and promote early detection. Timely recognition is essential. Perform self-assessment regarding possible feelings of frustration, anger, or fear when performing daily care for clients who have progressive cognitive decline. Nursing interventions are focused on protecting the client from injury as well as promoting client dignity and quality of life. Provide for a safe and therapeutic environment. Assess for potential injury such as falls or wandering. Assign the client to a room close to the nurse's station. provide a room with low level of visual and auditory stimuli, provide for a well-lit environment minimizing contrasts and shadows. Cognitive support, provide compensatory memory aids such as clocks, calendars, photographs, memorabilia, reorient as necessary. Keep a consistent daily routine, maintain consistent caregivers, provide adequate lighting in the bathroom at night. Physical needs, monitor neurologic status, identify disturbances in physiologic status which can contribute to the cause of delirium, monitor vital signs. Tachycardia, elevate blood pressure, sweating, dilated pupils can be associated with delirium. Ensure adequate food and fluid intake. Underlying causes of delirium can result in electrolyte imbalance. Communication. Communicate in a calm, reassuring tone. Speak in positively worded phrases. Do not argue or request hallucinations or delusions. Break instructions and activities into short time frames. Avoid confrontation. Encourage family visitation as appropriate. Medications. Use caution when administering medications, PRN, for agitation or anxiety. Delirium. Medications can be underlying cause of delirium. Recognize medication reactions before delirium occurs. Pharmacological management focuses on the treatment of the underlying disorder. Antipsychotics or anti-anxiety medications may be prescribed. Neurocognitive disorders. Cholinesterase inhibitor medications, donepezil, rivastigmine, and galantamine, increase acetylcholine at anticholinergic synapses by inhibiting its breakdown by acetylcholine esterase, which increases the availability of acetylcholine at neurotransmitter receptor sites in the CNS. In some clients, these medications improve the ability to perform self-care and slow cognitive deterioration of Alzheimer's disease in the mild to moderate stages. Adverse effects. GI, nausea, vomiting, and diarrhea. Monitor for GI adverse effects and for fluid volume deficits. Promote adequate fluid intake. The provider may titrate the dosage to reduce GI effects. Bradycardia and syncope. Teach the family to monitor pulse rate for the client who lives at home. Contraindications. Cholinesterase inhibitors should be used with caution in clients who have pre-existing asthma or other obstructive pulmonary disorders. Bronchoconstriction can be caused by an increase of acetylcholine. Interactions. Concurrent use of NSAIDs, such as aspirin, can cause GI bleeding. Nursing actions. Assess the use of over-the-counter NSAIDs. Monitor for indications of GI bleeding. Antihistamines, TCAs, and conventional antipsychotics, medications that block the cholinergic receptors, can reduce the therapeutic effects of donepezil. Nursing actions. Use of cholinergic receptor blocking medications for clients taking any cholinesterase inhibitor is not recommended. Nursing administration. Dosage should start low and gradually be increased until adverse effects are no longer tolerable or medication is no longer beneficial. Monitor for adverse effects and educate the client and family about these effects. Taper medication when discontinuing to prevent abrupt progression of clinical manifestations. Medications. Mementine. Block the entry of calcium into nerve cells, thus slowing down brain cell death. Mementine is approved for moderate to severe stages of AD. Nursing actions. Mementine can be used concurrently with the cholinesterase inhibitor. Administer the medication with or without food. Monitor for common adverse effects, including dizziness, headache, confusion, and constipation. Other medications may be prescribed include selective serotonin reuptake inhibitors for depression and anti-anxiety agents as needed for agitation. Antipsychotics are reserved for clients who experience hallucinations or delusions but are used as a last resort because these medications carry many adverse effects. Alternative therapies. Some vitamins and herbal products are currently under investigation for the treatment of neurocognitive disorders. There is currently no evidence that these products are effective. Client education. Questions to ask. Will the client wander into the street if the doors are left unlocked? Is the client able to remember their address and name? Does the client harm the others when allowed to wander in a long-term care facility? Home safety measures. Remove scattered rugs. Install door locks that cannot be easily opened. Place mattress on the floor. Remove clutter, keeping clear, wide pathways for walking through a room. Secure electrical cords to baseboards. Install handrails in bathrooms. Allow for safe pacing and wandering. Support for caregivers. Review resources available to the family as client's health declines. Include long-term care options. A variety of home care and community resources can be available in many areas of the country. These resources can allow the client to remain at home rather than in a care facility. Encourage caregivers to take care of themselves and to take one day at a time.